Start again. Hi, I'm Lakshmi Nagarajan and I work at the Perth Children's Hospital. I used to do a lot of adult epilepsy when I was in Queensland, but in Perth I only am involved mainly with children and families with epilepsy. I'm going to talk about the vagal nerve stimulation therapy for epilepsy. It is one of the neurostimulation techniques that we can use for seizures. You just heard there are 27,000. No,
If
not yet.
not picking up, just try holding it from here so it's closer to you.
We heard that there were 27,000 people with epilepsy in WA, and across the world, we know that there are more than 50 million people with epilepsy. And we have a lot of anti-seizure medications now, but despite that, the number of people whose seizures are not fully controlled with anti-seizure medications is about 30%. It still has remained around that. And some of the people where drugs don't work might have surgery as an option, but that's only a small number. Some may respond to some diets that are specifically tailored for epilepsy. Again, it's a very small number. And for those whose epilepsy is drug resistant and not suitable for surgical intervention, the therapeutic options are often quite limited and may not achieve seizure freedom. And neurostimulation may be useful, and the techniques that are used are they're divided into those that are called invasive neurostimulation techniques, which would be the vagal nerve stimulator, deep brain stimulation, and what is called as responsive neurostimulation. So the vagal nerve stimulation uses the vagus nerve to stimulate and modulate brain circuits. The deep brain stimulation uses electrodes that are placed deep in the brain, often in the thalamus, which is right in the middle, and again to try and achieve the same response. And responsive neurostimulation is where you have a way of detecting a seizure and then providing stimulation to influence the electrical activity and stop the seizure. Then there are two newer techniques, which are called non-invasive brain stimulation techniques that are in the clinical research arena still. They're not available as options for regular use, and that's transcranial direct current stimulation and transcranial magnetic stimulation. So what transcranial direct current stimulation does is uses a small amount of current that is applied to the surface on your scalp, and that influences the electrical networks in the brain and can influence seizures and reduce seizures. And transcranial magnetic stimulation uses a machine which generates a magnetic field, and that influences the electrical activity in the brain, and that can change the seizures and try and prevent seizures and try and stop the seizures. These are just two pictures illustrating. To the left of your screen shows the invasive neurostimulation. So the vagus nerve is the one with the two long strips that you see going down towards the body, and the deep brain stimulation of the thalamus, which is right in the middle, that is deep brain stimulation. And responsive neurostimulation can be, you can put electrodes on the surface of the brain, detect a seizure and give it, or put it into different areas of the brain where it detects a seizure, and then you give a current to try and stop that seizure. And on your right is non-invasive brain stimulation, where you can see those two little electrodes that sit on the surface that provide electrical stimulation. So you put the point where the current enters on top of where you think the seizures come from, and you try and influence it. And the other one is the TMS coil that you can see, which is transcranial magnetic stimulation, again to try and influence the electrical activity in the brain. With neurostimulation in childhood, there are less trials, less information, but it appears that it's as effective as it is in the adults. So most of the trials have been in the adults, and but now we're getting more and more information in children as well. Sorry. And when in 2021, when someone tried to look at all the papers that are available to look at efficacy, how does it work, what they found that with the invasive brain stimulation techniques, about 50% will get a 50% reduction in seizures. And unfortunately, with what we know now, only few people become seizure-free with the neurostimulation techniques. And in the VNS, the vagal nerve stimulation therapy, is the best studied neurostimulation modality and has become an important treatment option for people with drug-resistant epilepsy. It's been found to be effective in all kinds of seizures, focal seizures, generalized seizures, and syndromic epilepsy. When you say Lennox-Gastaut syndrome, Dravet syndrome, or a genetic epilepsy that you're able to identify the gene for. That's the vagus nerve that comes out. It comes from the brainstem. It's called the 10th cranial nerve. It innervates lots of parts of your body, your heart, your lungs, your gastrointestinal tract, and it gets information from all these parts. And then it projects to a lot of areas in the brain. And this is just a pictorial representation of where the vagus nerve stimulator is. Which side shall I go? Is this working? No. Okay, I shall refrain. You can see the orange stalk like coming. That's your brain. That's the spinal cord going into the brainstem. And the vagus nerve projects to a lot of areas in the brainstem. And it influences not only the electrical activity there, it also influences the neurotransmitters over there, different kinds of chemoreceptors there. And these areas project to different parts of the brain, and therefore it can affect the activity in different parts of the brain. We think when there is a seizure, there's an imbalance between the neuroexcitatory activity and the neuroinhibitory activity, which balances out things usually. But if there's too much neuroexcitation, relatively too much excitation, you could have a seizure. And it happens when lots of cells in the brain sort of fire together synchronously. And what the VNS is thought to do is reduce this excessive synchronized activity in the brain that produces a seizure. The first patient who had a VNS inserted was in 1988. And thanks to LivaNova for the data, about globally, more than 175,000 people have had the VNS inserted, and more than probably 50,000 are children. In Australia, we've been trying to get accurate figures, but there are about 1,000, and the ratio between adults and children is probably 80 to 20. Now, this is a picture of a child who was implanted with a vagal nerve stimulator when he was a teenager, and this was in the late 1990s. Dr. Walsh, who is a pediatric neurologist here, who was just retired, was the first neurologist in Australia to go ahead with having a child with refractory epilepsy be implanted with a vagal nerve stimulator. And so what it does is there is like a pacemaker which sits just below in this region, sort of right. We used to put it right closer to the midline. Now we tend to put it towards the axilla because it's less obvious. And we used to do a scar which went up and down. Now we do it this way because there's less scarring if you go horizontally rather than vertically. This is our first computer that we used to program the device. It's basically the same technology. It's just become more compact and easier to use. So you use the device that's there, and you can program the stimulator to give different types of current at different frequencies. If you look at that slide there, at the beginning where it says signal frequency, so the current can be, usually it's around 20 hertz or 30 hertz, but you can change it. Then this pulse width is there, it comes on for a certain amount of time, which is the signal on time, and then it stops for a certain amount of time. So you can turn it on for 20 seconds, 30 seconds, 7 seconds, and you can turn it off. Conventionally, we used to turn it off for 3 to 5 minutes, but you can also do rapid cycling. So you turn it off, you can give it for 7 seconds and turn it off for 40 seconds. You can set it to deliver what you think would be the best paradigm for the person. And again, each pulse, you can have, how wide it is. It can be 250 microseconds, it can be 500 microseconds. And you try and find the best stimulus paradigm for each person. There are some guidelines, but there's a lot of variability in people's responses, in clinicians' preferences as to what the paradigms are. And this is, I just thought, when we first started the VNS at PMH, this was in the late 90s. And we looked at afterwards, soon after, in a few years, we looked at the first 16 children that we'd undertaken the VNS for. All of them had very difficult to treat epilepsy. They tried many different anti-seizure medications. They were not candidates for surgery or had failed surgery or did not want surgery. And the median time of seizure onset was 12 months, so very early onset epilepsy, which is often difficult. And many had a significant intellectual disability. We found that there was a greater than 50% reduction in 62.5% of the children. And over this time, all these decades, the response rate is still around there. And we did have in the first 16, more than 25% got a 90% seizure reduction. But if you look at our numbers now, we haven't got that higher response of greater than 90%. And seizure severity reduced in quite a few, seizure duration shortened in quite a few, and rescue medication, at that time we used to use rectal diazepam as rescue, that also reduced. And there was improvement in quality of life, in awareness, in alertness, which was a significant benefit. It was tolerated in all but one person in the cohort. We also looked at, very early on, one of the people who looked at respiratory pattern changes in children when you use the vagal nerve stimulation for epilepsy. And it was because one child's mother told us, overnight I'm sitting there and I know when it's coming on. I can see his breathing pattern changing and I'm worried. So we looked at 8 children who did a sleep study on them, and we found that, as it almost always is the case, mothers are right or fathers are right, and there was a decrease in the effort during, how much you breathe in and out, how much air moves in and out, in 7 out of those 8 children. And that in one child, the respiratory rate decreased, in the others it increased, but in none of them, thankfully, did it actually cause any clinical problem. The drop in saturation in your blood of oxygen was not significant. The maximum was 3% and it was acceptable. And there's now been a lot of work on this area, and we're still trying to understand this. And I thought that I'd put a picture of one of the children's polysomnograph. It looks very complicated, I know, but it's because there's so many things on the picture. On the top slides, on the top bits there, I'll try not to fall. Where you can see on top, where that's the EEG. And then over here is where the stimulator is coming on every 5 minutes. And we've just taken 1 minute of that here. So the stimulator is coming all over here. And this is the airflow in and out of your lungs, and it changes and becomes a bit low. And it's only of clinical significance if you already have problems with with apneas and respiratory problems, and you have to be aware of it and look for it. But in most people, it is not clinically significant. When the largest multi-center randomized active control trials of VNS was in adults, and I was doing my epilepsy fellowship in New York at that time, so I was involved with some of those people there. And so what it found was that in the high stimulation group, there was an average of 28% reduction in seizure frequency. There were improvement in global evaluation scores, but there was no significant change in your gastric function, your lung function, your heart function, because as I remember, VNS is involved, gets information from there, sends information to a lot of the organs, and therefore felt that it was a safe option. However, at that time, a randomized controlled trial in children only showed a 50% reduction in 20% of children. There was subsequently a larger study which showed that there was a greater than 50% reduction of seizures in about 32% at 6 months, a little bit higher at 12 months, and about 44% at 24 months, saying that the seizure reduction may improve with time. And this is borne out with adult data as well over years. There's also favorable change in seizure duration, seizure severity, post-ictal severity when you're confused or you're tired and sleepy, and that it's a safe option. There have been lots of randomized trials, open case series, and the responder rate has varied. It's anywhere between, actually I put 40, but 30 to 70% in the different groups when you look at all the studies. And in Lennox-Gastaut syndrome, this might be something that you may want to look at. It's reported, it's a summary of the vagal nerve stimulation for people with Lennox-Gastaut syndrome, which is a severe childhood onset epilepsy, and explaining that where there were 60 patients in this group, they had improved, the VNS helped improve seizure numbers up to about 2 years after starting. It kept getting a little better. And VNS may reduce all types of seizures because people with Lennox-Gastaut syndrome drop seizures, they have generalized convulsive seizures, they have atypical absences. So it helped improve all the seizure types. And it was, especially in older people or in adults, where it's more, it reduced the number of falls, it reduced the number of hospital visits, and it did improve quality of life. And there is another study that looked at the different forms, not a study, a systematic review looking at all the literature in the different areas of studies reporting on response to vagal nerve stimulation, to deep brain stimulation, and responsive neurostimulation. And in the 5 observational studies that fulfill the criteria to do this analysis at that time with VNS, there was a pooled mean decrease in seizure frequency of about 35%. And for responsive neurostimulation, it was higher and it kept improving with time. For DBS, again, the median reduction was slightly higher and did improve with time. The data regarding VNS improving after 2 years, there's not that much data. There is data till 2 years saying it does get better. And quality of life improved with any of the neurostimulation techniques in most people. Now, cost effectiveness is important. When we started doing the VNS in NPMH, we had to find money for each child to do it. The Rotary Club has provided, people have gone and raised funds from the community, and then the hospital decided they will fund 2 children to have VNS each year. So, but now we can, we are able to do as many VNS as we think it's necessary. And there are people looked at 3 economic dimensions when they looked at cost effectiveness: the direct medical costs, the admission, the actual device, the surgery, and then the indirect societal costs. How many days of not working? How many days of someone else having to take time off because there are increased seizures in the person? And then the long-term economic benefits. Their analysis revealed that there was remarkable long-term cost effectiveness. It was difficult to show short-term cost effectiveness. And they found that the VNS therapy reduced healthcare utilization, medication costs, and socioeconomic burdens associated with uncontrolled epilepsy. Now, side effects. That often is sometimes limiting what we can use. But VNS seems to, in our experience and in the experience for lots of people across the world, it seems to be fairly well tolerated. Voice alteration is the most common thing people report, and hoarseness, throat pain, coughing, shortness of breath, tingling, muscle pain around the site are things that are, after voice alteration, probably the most common side effects. We've only had one teenager who was tolerating the VNS. It was good. It did reduce his seizures by 50% at least. But then he had a bad throat infection. And after that, he just couldn't tolerate the VNS. And so we had to turn it off because he couldn't, it really set him off, being very upset. But other than that, we've not had to turn off the VNS because of side effects with almost anyone except one person where it didn't work and we decided the family wanted to turn off. You can have infection with any surgical incision, surgical implant. We've had one infection over all these years where we had to give IV antibiotics, but occasionally you may have to take that off because it's a foreign device. And if it gets infected, then you can't leave it in. Bradycardia, people have all talked about it because the vagus nerve stimulator supply, it has inputs to the heart, gets inputs from the heart. People been worried. And the thinking was that we should use only the left side because that would influence the heart rate less. But now we ourselves have one child who has had it implanted on the right side. And in the literature now, there are many more reports, and it does not seem to be cardiac dysfunction has not been such an issue as people thought it might be. But so it can be done on the other side as well. However, if you have a cardiac conduction defect, where there's some abnormality in the way the heart is conducting to different regions, you have to assess each person to see if its VNS is safe in that situation. Vocal cord paralysis because of surgery occurs in about 1%, but it almost always recovers. However, there is a rare delayed permanent cord paralysis, which is due to people twiddling with their device, pulling it, pushing it. And this apparently also happens with cardiac pacemakers, that people fiddle with it, and that causes it to break or scarring around it and may cause problems. Aspiration with VNS, if you have severe gastroesophageal reflux, and sometimes happens with some of the children we see with intellectual disability, bad GI reflex, then you have to be aware of it and treat it. Weight loss may occur with VNS, well documented. The role for treatment of obesity is controversial. They looked at it at one point, but it's not actually gained traction. The weight loss may occur. Sometimes you may need to supplement the diet to make sure to compensate for it, especially if it's been good for seizures. Sleep apnea is a relative contraindication, but it's not an absolute contraindication. You need to work out why there's sleep apnea. If you can correct it, address it, because VNS may worsen it. But in most people, it does not affect respiratory function. And it does, as I showed you on that picture, there is more frequent hypopneas in sleep, but it does not appear to be clinically relevant. The non-seizure outcomes, the quality of life has improved in most studies and greatest in those who have the highest seizure reduction. Mood, it's inconclusive, even though there are some studies which suggest that it improves. Overall, we're not sure. But VNS is being explored for major depression in people who don't have epilepsy as well. Daytime sleepiness, most studies report actually improvement in daytime sleepiness in spite of the things that happen in sleep. And some of the things is that maybe low intensity stimulation may improve daytime alertness more than high. By low intensity, you mean the current, the strength of the current that you're using with the vagus nerve stimulator. And that if you have very high intensity stimulation, the amount of rapid eye movement sleep may be decreased. Behavior may improve in children with autism and intellectual disability, and this may be even independent of seizure control. And in adults, cognition does not appear to be positively or negatively affected if you look at the whole, all the people with vagus nerve stimulation. So it doesn't worsen it. Overall, in an individual, it might be different, but overall, it does neither. Anti-seizure medications, we always think and hope that we are able to get rid of the anti-seizure medications, or at least reduce the number. But most continue to need, and most, if you pool the data, not many people are able to reduce the number of anti-seizure medications they're on with the VNS. Small studies have shown that yes, you can, but I think the hope is with time, as we learn more, that we are at least able to reduce the amount of medication, if not the number. Neither sudden death nor overall mortality that is associated with epilepsy appears to be increased when you have the vagal nerve stimulator in. And there's some data suggesting that it may reduce the rates of sudden unexpected death in epilepsy. Now, again, to just reinforce, remember I told you can do things with the current, the number of times it comes on, the width of each pulse of current, the amount of time you have it on, and the amount of time you have it off. Previously, conventionally, we used to do 30 seconds on, 3 to 5 minutes off. But there is also rapid cycling mode where you can go much faster, where your off time is 1 minute or less. And the newer devices with the vagal nerve stimulator, you can change how much you give in the daytime and what you give at nighttime. And you can also use the magnet for when you have a seizure, or you have an aura, you give yourself an impulse, or somebody else gives an impulse at that time, a stimulus at that time, and that may stop the seizure or prevent it from being a longer seizure or prevent it from becoming a bigger seizure. Overall data with the magnet seems to be about 25% effect, works in 25%. It's more useful if you have got a focal seizure and you know it's coming. In many of our children, we have not found it to be very useful. Maybe less than 25% that it's still being used once we've tried it. And then there are other VNS responsive devices now, where, as we said, you can have automatic intermittent stimulation, and then, but in addition to the on-demand stimulation. So you have these where your heart rate is detected, and we know that when you have a seizure, the heart rate increases with a lot of seizures very fast. So there are programs that pick up the rate of the heart rate increase and can give a stimulus at that time. And there's data, at least strong data in the adults, that this might also help improve seizure outcomes. And but also, when they've looked at what is happening with the heart rate increase, there are seizure-related and non-seizure-related increases in heart rate in our day-to-day life. You get angry, your heart rate is up. You're running, your heart rate is up. So you do get, it may not just be the seizures that trigger the extra stimulation. And direct comparisons between responsive neurostimulation, for example, with the heart rate, and conventional neurostimulation is hard because most of the studies compare this to what happened before. It's hard, but ideally it would be nice to do it without the responsive stimulation, and then in the same person add the responsive stimulation to see how much more effective that makes it. And as I said, we can do different stimulation for day and night. And then there are people are working on having vagal nerve stimulators that detect the afferent activity in the vagus nerve and then decide how much stimulation to give. And ones that when now current ones, not only does it go to the brain when you stimulate the vagus nerve, but there's some downstream effects goes to other organs as well. And that trying to prevent that from happening. It's still the most widely used neuromodulation therapy across the world, can be helpful in people who have seizures that don't respond to medications, who are not candidates for epilepsy surgery, who do not want epilepsy surgery, or where epilepsy surgery has not worked. It can be used for a wide variety of etiologies and a wide variety of epilepsy types. And a recent large global study from Melbourne or Melbourne coordinated this study where they collected data. This was in adults, that the people use an average of 7 anti-seizure medications before attempting VNS therapy. And that it takes about 10 years for people from time epilepsy seizures have started for implant of the VNS. So we do need to identify factors that predict a clinical response, because they still remain elusive. With all the number of people we know, we've looked at, that it's still very hard to predict who is going to respond. If you have seizures that start early in life, they seem to respond less. If you use it earlier, it seems to respond more. So there are some things we are sort of getting at, but in an individual person, it's still difficult to say, is this person going to be in the more than 50% or less than 50% response to seizures? We do need treatment guidelines, but it's difficult to develop guidelines without having good data to underpin what you're providing a guideline with. But it is a modality that should be considered and can be used if the epilepsy is difficult to treat with just anti-seizure medications or side effects are too high. Thank you.
We have a couple of minutes.
Yeah.
We do have a couple of minutes. So does anyone want to ask a question? Can I give you that microphone?
Sure.
And I'm assuming that this one will work. It does. Here we go.
I just wanted to know how the stimulator's powered. If it's an implantable battery, does that run out, or is there a
Yes.
lifetime of the device? And
There is currently there is a lifetime of the device. It's longer than it used to be, but it also lifetime is also influenced by your duty cycle, like how much you're using it. If you're using rapid cycle, it goes away earlier. But it's more than 10 years in whatever with current things for, and you can just replace this end with that you just take out the pacemaker kind of device that sits there. You don't have to go and touch the rest of the thing. But they're also working on devices that you don't have to replace.
so you could charge
They're working on it. It's not available right now. It is still with time. It will, but now there are things on the computer program. So when you access the device, it will tell you where the battery life is, and is it time to consider coming off or not. Yeah. A lot of people do actually. The number of reimplantations is quite high, so it's well tolerated. And sometimes people want it because they feel quality of life has been much improved, even though the seizure outcome may be a bit not as good as we would like.
Hi, thank you. My name's Kat. I just was wondering, would this be available for people who have severe disabilities who refuse to take medication? So like who are medication resistant or non-compliant?
I think that there are ways of addressing medication, not being able to get medications in. Like we do try sometimes. Yeah, you probably know. Occasionally we use nasogastric tubes to get medications in. Occasionally we use gastrostomies to get medications in. It is probably more expensive, response rates are probably less than with medications. Like you can get seizure freedom, a much higher rate of seizure freedom with medications in most people with epilepsy. So you wouldn't go to it as your first option. No. But yes, but there are people, and especially adults, who elect to have the VNS so that they don't need to take medications. I know in America there's a cohort that they've actually looked at as well with that.
Yeah. Hello. I'm just wondering, has results from these studies, have this included for with VNS? Is this also people with drug-resistant epilepsy who are able to notice who aren't unaware that they don't have seizure, or these?
Most of the studies have been people who have reported, or people who are with them who have reported the number of seizures. But there are a lot of studies who also looked at EEGs to see and quantify on video EEG studies. Like, not obviously can't do it every day, But over time, periodically looking at it and shown that not only seizures, but also interictal epileptiform discharges can decrease. Like the in-between seizures, the biomarker for saying you have epilepsy or you're likely to have seizures, that can also decrease.
With the people with the VNS, they don't actually, beforehand, they didn't actually, weren't able to tell that they were going to have a seizure was coming, essentially. So they didn't know, weren't able to tell they had a seizure was coming.
They still may not be able to tell when the seizure is coming in that situation. But sometimes if the severity of a seizure reduces, you might be able to have, or the time that it's a milder seizure, you may be able to detect it.
I'm just wondering, sometimes you get people who don't even recognise you're going to have a seizure, and they end up saying you're not having a seizure when you can have little absent seizures, and then before you know it, they develop into a grand mal, and by then you get diagnosed, but the damage has already been done. Is there anything looking into early diagnosis with absent seizures?
The VNS particularly, no, it does not help early diagnosis of absent seizures, but an EEG will often pick up absent seizures. Like in childhood, if you have childhood absence epilepsy, your first EEG in 90% will show epileptiform discharges. In adults, it's not necessarily so because what you call absence may not be a generalized absence seizure. It often is a focal seizure with impaired awareness, and they may not be picked up even on the first EEG. And even if you do 3 EEGs in a row, over time, only 60 to 70% will show up on an EEG. So yes, sometimes it can be difficult, and it has to be a combination of a good history of people being able to get videos now and looking at it and then putting it together.
Last question, the gentleman in the middle.
1,000 people seems to be very small uptake, from what I can see. Other than drug resistance, what sort of criteria would you possibly advise a person take to consider this sort of treatment?
I think there's several things that you need to consider. Now, money is not we don't need to consider in Australia, but lots of parts of the world, it is a consideration because it's quite costly. But it's the seizure, how frequently you have seizures. For very short seizures, like frequent absences, it's more difficult. And maybe rapid cycling will help more. But it's not drug resistant epilepsy is one, but even those who had surgery and it hasn't worked, whether you go for the ketogenic diet first or the VNS first, as both are options, also depends on the child and the cognitive status of the child and whether they will, or the adult person, if they want to try a diet, which also can be restrictive, or they would prefer to go to a vagus nerve stimulator. The data does not tell you this is the better modality. Like they're both work in about half.